Hello, my name is Dakota Sechena, and this is my Diabetic Educational Intervention Project. This study was a quantitative quality improvement diabetic educational intervention that was implemented to increase knowledge on diet and exercise for patients with type 2 diabetes. The research findings demonstrated that an educational intervention regarding diet and exercise helped to improve self-reported fasting blood glucose levels, which aligns with the aims of the scholarly project. Phenomenon of interest. Providing diabetic educations to patients and their families is essential in preventing complications and delivering effective diabetic care. With the population aging and sedentary lifestyles increasing, the prevalence of type 2 diabetes has increased throughout the world. Worldwide, it is estimated that 415 million people between the ages of 20 and 79 are diabetic. Increasing patient awareness of diabetes through education helps to improve overall patient health. Successful diabetic education improves awareness of diabetic symptoms and assists diabetic patients to adopt practices focused on symptom management and prevention of complications. Proper education helps provide patients with the knowledge to self-manage their condition and make proper lifestyle changes to increase their overall health. By providing patients with the knowledge to make lifestyle changes to increase their health, it allows them to live a better, healthier, more productive life. Educational programs that help patients eat healthily and add more physical activity to their day provide patients with the education needed to improve their health. The Centers of Disease Control and Prevention recommend implementing lifestyle change programs for patients to receive a thorough education and make lasting changes to prevent and delay complications from their type 2 diabetes. Education has been able to demonstrate assistance to enable people to develop their skills needed to self-manage their condition. Improving a patient's knowledge of diabetes through education increases a patient's ability to recognize signs and symptoms while preventing diabetes. Providing patients education on self-management of their diabetes through diet and exercise is essential to achieving and maintaining reasonable glycemic control. Ensuring proper glycemic control is the primary goal for diabetic management as it reduces complications. Providing educations helps patients increase their knowledge about diabetes, self-management, and provide them with a sense of personal responsibility for taking control of and bettering their health. Diabetic patients have complex changes that need to be implemented in their daily lives to maintain effective glycemic control. Self-management educational programs help to bring behavior changes in patients by improving their knowledge in order to better control their condition and overall health. Interest and expertise. Personal interest in diabetes comes from seeing diabetic patients admitted to the hospital with diabetic complications. Often these patients lack the education and knowledge needed to modify their risk factors to control their diabetes appropriately. Personal expertise comes from working in a cardiac intensive care unit. Diabetes is associated with an increased risk of cardiovascular complications. Personal interest in this topic arises from working with patients at the hospital with a history of diabetes and multiple other comorbidities. Some patients express an unawareness regarding proper nutrition to control their diabetes and lifestyle modifications regarding the proper use of medication and exercise. Increasing education in the community can help prevent patients from suffering from diabetic complications. Background information. Type 2 diabetes is a chronic condition that is associated with adverse health problems. An increase in education means a decrease in complications and an improvement in patient quality of life. Diabetic patients are at risk for developing peripheral neuropathy, ischemia, cardiac, renal, neurologic, and vascular system problems. It is estimated that around 30 million diabetic patients live in the United States, with another 84 million pre-diabetic patients in the United States. These numbers have continued to increase, leading to a growing need for education in these problems. Continued education can help prevent costly physical and financial complications to patients. The PICO question for this project is In adults with type 2 diabetes who attend a diabetic support group, how does one educational session on self-management of diet and exercise impact their self-reported blood glucose levels? Aims. The aim of this project is to increase knowledge on diet and exercise for patients with type 2 diabetes. This is the project implementation timeline diagram. From June 2020 to August 2020, there was a needs assessment that was completed. In addition, at this time, collaboration with the clinic, nurse practitioner in the clinic, and office manager occurred. Education. Diabetic educational research occurred during September 2020 to December 2020. IRB approval. From January 2021 to April 2021, the Maryville IRB application was submitted and it was approved. Implementation. November 2021 to December 21. The diabetic educational sessions occurred during this time frame. 1 month after the diabetic educational session, there was a follow-up phone call in order to record the self-reported fasting blood glucose levels. Results. From January 2022 to February 2022, there was a data analysis that occurred. Methods. Step 1. After IRB approval had been obtained from Maryville University, the nurse manager created a list of potential participants. Step 2. The nurse manager created a report identifying patients with a diagnosis code of type 2 diabetes. Step 3. From the list, the nurse manager selected male and female patients between the ages of 18 and 89. Step 4. The author reviewed the list and sent recruitment letters as well as recruitment phone calls to all potential participants, asking them to participate in the diabetic educational session. Step 5. Participants were offered the opportunity to participate in a group-based diabetic educational session. Step 6. The participants were offered an option of 2 different days/times to participate in the diabetic educational session. Step 7. When participants arrived for the diabetic educational intervention session, they were given a consent form and a demographic survey. Information such as age, race, and gender were collected. The survey also included the last reported fasting blood glucose level, dietary practices, exercise practices, and methods of contact. Step 8. Participants were given a 1-hour group-based educational session on diabetic management, which included diet and exercise regimens. Participants were allowed to ask questions at the end of the session. Step 9. 1 month after the session, participants received a follow-up phone call to record their self-reported fasting blood glucose level. This was the results. This is the demographic data that I collected. Descriptive statistics were utilized to describe a population and summarize the sample population that was being studied. Descriptive statistics are important as they help provide insight into quantitative research findings. In the diabetic educational intervention study, descriptive statistics were utilized to analyze the demographic data. In the study, demographic data included age, sex, and race. The sample population was 100% Caucasian. Of the sample population identified their race as being Caucasian. Of the sample population, 37.5 or 3 of the participants were male and 62.5% or 5 of the participants were female. Fasting blood glucose pre- and post-intervention results. The variability in the study reflects how much data is dispersed. The range of the variability is the highest score minus the lowest score in the data collection set. The size of the study included 8 participants that participated in a pre-test and a post-test. The pre- and post-test was their fasting blood glucose levels. The pre-intervention fasting blood glucose levels ranged from 126 to 268, resulting in a variability of 142. The post-intervention fasting blood glucose level ranged from 120 to 235, resulting in a variability of 115. There was no missing data in this project. Data collection was maximized with the study protocol design. Well, 71 patients met the inclusion criteria. Only 8 participated in the project. When recruiting participants, all patients meeting inclusion criteria were sent a letter and called twice to recruit them for the project. If the patient did not answer after 2 phone calls and a letter, they were considered a non-response and not included as a participant in this project. Diabetic dietary practices. In the pre-intervention survey, a question was about their diabetic dietary practices. The choices included never following a diabetic diet, follows a diabetic diet less than 50% of the time, follows a diabetic diet greater than 50% of the time, and always follows a diabetic diet. Exercise frequency. Another question on the pre-intervention survey was how frequently participants exercise. The choices included 0 days a week, 1 to 2 days a week, 3 to 4 days a week, and greater than 5 days a week. A Wilcoxon-signed ranks test was used to determine the statistical significance of the difference in the pre- and post-intervention fasting blood glucose level. The Wilcoxon-signed ranks test indicated that the post-fasting blood glucose level was statistically different than the pre-intervention fasting blood glucose level, with a power of 0.8463. There was statistical significance between the pre-test and post-test blood glucose readings, with a probability error of 0.8463, which is considered strong. The Wilcoxon-signed ranks test match pairs revealed that the diabetic education intervention provided to patients with type 2 diabetes proved to be effective for improving fasting blood glucose readings. Reported alpha error probability was 0.05. There was a statistical significance found between the pre-intervention fasting blood glucose level and the post-intervention fasting blood glucose level. Analysis. Implementing a diabetic educational intervention improved fasting blood glucose levels. Discussion. Strengths. The strengths of the study included that, to the author's knowledge, this was the first study at this particular clinic evaluating the importance of diabetic education and its relationship to a patient's self-reported fasting blood glucose level. An additional strength of this project included providing additional recognition to patients in the clinic about needing to better control their fasting blood glucose levels. Limitations. The results of the study may have been affected by the relatively short period that this project was implemented. The participants provided a self-reported fasting blood glucose level, were then given a 1-hour diabetic educational session, and then had a follow-up phone call 1 month later to assess their self-reported fasting blood glucose level. As the follow-up period was relatively short, a limitation could be that participants were not followed up with over an extended period to determine if they would have a sustainable reduction in their fasting blood glucose level. Another potential limitation involves using the participants' self-reported fasting blood glucose. The participants were self-reporting their fasting blood glucose level, which could have impacted the results. Another limitation could have been the fact that self-reported fasting blood glucose levels were utilized instead of a hemoglobin A1C, which would have been useful in assessing the average blood glucose level over a period of 3 months. A potential source of bias in the study occurred during patient recruitment. As some patients are more likely to enter the study than others, the sample may not necessarily represent the entire population in which the research was done. Another source of potential bias for the study was that inclusion criteria included English speakers only, due to the inability of the researcher to have a translator. As the region where the study occurred had a high Spanish-speaking population, these patients were excluded from participation in the study. These exclusions would make it difficult for the sample to represent the entire population in which the research was done. As the study was implemented at one rural healthcare clinic in the western region of the United States, it would be difficult to generalize the findings. To be able to generalize the findings, the study would need to be implemented across multiple healthcare clinics throughout the entire country. As this project took place in a specific healthcare clinic and was not implemented at multiple healthcare clinics across multiple regions, it would be difficult to generalize the findings. In addition, Spanish-speaking participants were excluded from the study due to the inability of the researcher to be able to translate. This would make it difficult for the results to be generalized to the entire clinic or to the entire region. The results could be sustained if the project was completed again. If similar inclusion and exclusion criteria were implemented, a similar follow-up period, and the utilization of self-reported fasting blood glucose levels, it is predicted that the results could be sustained again in the future. The project followed a very specific methodology, making it feasible to represent the study under similar circumstances. Minimizing the limitations was difficult, as Spanish speakers do make up a portion of the patients seen at the clinic where the project was implemented. As Spanish speakers were excluded from the project due to the inability of the researcher to be a translator, this was a limitation that made it difficult to be minimized. The participants were followed up 1 month after the educational session and were asked if they had any questions regarding the education they were provided. This helped with clarifying any questions that the participant may have developed through the follow-up period. As the patients were responsible for taking their self-reported fasting blood glucose level, this would not have had a significant variation in the pre- and post blood glucose levels, as the participants were taking both of these levels themselves. The participants also followed up with their primary care provider at the clinic, where they would have had a hemoglobin A1C level taken regularly. The effects of the limitations of the study may have affected the overall results. Excluding Spanish speakers in the project makes it difficult to generalize the findings. In addition, the follow-up period within 1 month was helpful, as it provided immediate feedback for the intervention of the project. Following up over an extended period of time could have been important, as it would have given a better idea of how sustainable the intervention was for the participants. Discussion regarding the bias. Potential bias during recruitment, as some patients are more likely to enter the study than others. Another potential bias was English speakers were included only. The region had a high Spanish-speaking population, but due to the researcher being unable to translate, these patients were excluded from the project. Implications for future research, practice and future research. For future research, it would be important to follow up with participants for a longer period of time. Taking a pre-intervention hemoglobin A1C and a 3-month post-hemoglobin A1C would better assess how the patient's blood glucose readings are doing over a longer period of time. A fasting blood glucose level is important, but can vary by the day, depending on how well the patient followed a dietary and exercise guidelines. A hemoglobin A1C would be helpful, as it would assess over a 3-month period how well the patient was doing. In the future, multiple diabetic educational sessions would be very important. As the diabetic intervention session focused on diet and exercise, doing multiple sessions to reinforce the education provided and expand the education would be helpful in future practice and research. Implications for future research healthcare policy. Implications for future healthcare policy should be centered around improving diabetes. Individuals at high risk for diabetes include those with impaired fasting glucose readings, impaired glucose tolerance, obesity, close relatives with type 2 diabetes, and members of certain ethnic groups such as Asians, Hispanics, and African Americans. Implementing education regarding lifestyle modifications as part of the health care prevention for high-risk groups would be important in the future as preventative interventions. Implementing diabetic education on high-risk groups in the future can help prevent or delay the onset of diabetes, preventing microvascular and cardiovascular complications, and overall reduction of the cost of diabetes care. As healthcare costs continue to rise, implementing policies to focus on lifestyle modifications to improve diabetes would be cost-effective measures to be implemented in future healthcare policies. Diabetic education has multiple implications for healthcare quality and safety. One of the implications is improving blood glucose readings in order to help decrease long-term effects of diabetes. As poor controlled diabetes has microvascular and macrovascular complications, it is important to treat in order to decrease complications. Typical microvascular complications include retinopathy and neuropathy and can affect a patient's overall quality of life. Macrovascular complications include a correlation with a higher rate of cardiovascular disease. Improving a patient's blood glucose through lifestyle interventions can help improve a patient's quality of life and prevent long-term complications. Diabetic education centered on diet and exercise should be implemented in the management of all diabetic patients. These next slides were references that I had used in my presentation. And I just wanted to thank everybody for listening and let me know if you have any questions.